EUS-assisted double-lamp septotomy for permanent partial reversal of Roux-en-Y gastric bypass. These are our disclosures. Roux-en-Y gastric bypass is a highly durable and metabolically impactful intervention. Up to 2.3% of patients will experience debilitating complications such as severe protein-calorie malnutrition, refractory dumping syndrome, and refractory postprandial hyperinsulinemic hypoglycemia, and will require surgical reversal of the bypass. Traditional reversal surgery is technically demanding and highly morbid, with up to 35% of patients developing perioperative complications. In recent years, lumen-apposing metal stents have been used to create stable gastrogastric fistulas. GG fistulae, once created, allow for ingested food to be partially shunted into the excluded stomach, facilitating absorption of nutrients and resulting in weight gain. It has therefore been used in patients with malnutrition or indications for bypass reversal. Prolonged lamb's dwell time unfortunately is associated with complications and is therefore unsuitable for patients with long-term or permanent bypass reversal. There is an urgent need to develop a reliable technique to consolidate the GG anastomosis after stent removal. We present a 39-year-old male with a history of Roux-en-Y gastric bypass who was referred to our practice with severe malnutrition. Considering his poor surgical candidacy, it was decided to place a 20 mm lumen-apposing metal stent to partially reverse the patient's bypass. After a good clinical response and an increase in his BMI to 28, the patient decided not to undergo complete RYGB surgical reversal. After a multidisciplinary discussion, we decided to proceed with endoscopic consolidation of the GG fistula using the EUS-guided double LAMS technique. The following illustrations describe a two-step procedure that was used. During the first step of the procedure, two lumen-apposing metal stents are placed 1.5 to 2 centimeters apart. This may be done either during the same session or during different sessions to connect the gastric pouch with the excluded stomach. This establishes two fistulous tracts with an intervening tissue bridge or septum that comprises a full-thickness gastric pouch wall and excluded stomach wall. After 6 to 8 weeks, the patient is brought back and undergoes a second step of the procedure where the lumen-apposing metal stents are removed and the tissue bridge that connects the now established fistulous tracts is dissected completely. This maneuver creates a new and significantly larger gastrogastric anastomosis measuring approximately 2.5 to 3 centimeters with unrestricted flow of ingested food into the excluded stomach. The following video series describes the two-step procedure that was used in our patient. As seen here, the previously placed lumen-apposing metal stent remains in situ with only a mild tissue reaction around the proximal flange of the stent. The stent was then removed using a standard rat-toothed forceps. The stomach was then lavaged with a copious amount of water, and a target site for placement of a second lumen-apposing metal stent was identified approximately 1.5 to 2 centimeters from the site of the first LAMS. A 20 mm by 10 mm lumen-apposing metal stent was then placed freehand into the excluded stomach. The first lumen-apposing metal stent was then replaced endoscopically and the patient was discharged home on a soft diet. The patient progressed well and underwent step 2 of the procedure 2 months later. As seen here, both lumen-apposing stents were removed using standard rat-toothed forceps. In order to evaluate the entire thickness of the septum, the transducer of the EUS scope was passed through one of the fistulae into the excluded stomach that was then lavaged with a copious amount of water to better delineate the anatomy. The anastomosis measured approximately 2.5 centimeters and the septum measured approximately a centimeter with no significant vasculature noted on Doppler studies. A soft tip guide wire was then passed through one of the fistulas into the excluded stomach, and the scope was withdrawn, leaving the guide wire in place. The scope was then reintroduced alongside the guide wire and advanced into the excluded stomach through the second fistula. The soft end of the guide wire was grasped and the scope was withdrawn, leaving the guide wire loop in situ. As seen here, when external traction is applied to the wire loop, it hooks the septum and pulls it away from the posterior wall of the stomach and towards the operator. By doing so, the loop essentially serves as a surgical ligature would during a septotomy. This provides traction and guides the plane of dissection, therefore creating an effective counterforce when needed. Here we see complete takedown of the septum between the two fistulas and creation of a large GG anastomosis measuring approximately 2.5 centimeters. It is important to avoid lateral drift of the knife and inadvertent injury of the fistula wall and ensure that the plane of dissection is parallel to the wire loop at all times. Here we see the wire loop come loose after completion of the dissection. The guide wire is then withdrawn and a thorough examination of the dissection bed is performed to exclude any transmural defects. Subsequent injection of water-soluble contrast does not reveal a leak. A hemoclip is then placed on either side of the dissected septum for bleeding prophylaxis. Our patient did well and was given a dose of intraprocedural PPIs and IV antibiotics. The patient was started on a liquid diet for a week. We encountered no adverse events. There were no recurrence of symptoms on clinic follow-up, and the patient continues to maintain a healthy BMI. This is the upper endoscopy of the patient 5 months after septotomy. As seen here, the gastrogastric fistula appears well healed and epithelialized. Injection of water-soluble contrast demonstrates unrestricted flow into the excluded stomach. In conclusion, EUS-guided double-lamp septotomy is a technically feasible novel procedure that converts a stent-dependent gastrogastric fistula into a durable anastomosis without the need for high-risk surgery. This avoids long-term LAMS-related complications such as tissue ingrowth and stent migration. In our patient, this resulted in consolidation of a GG fistula that was created via EUS placement of 2 LAMs and permanent partial reversal of Roux-en-Y gastric bypass. This may offer a viable, less invasive, and durable alternative for patients with Roux-en-Y gastric bypass who require surgery. Larger prospective studies are needed to evaluate safety, efficacy, durability, and long-term benefits. Thank you for your attention.